Welcome everyone to a journey into the intricate world of cardiology. Today we're focusing on a rare and fascinating heart condition, Libman-Sacks endocarditis, often abbreviated as LSE. Join us as we explore its origins, how it affects the heart, and what can be done about it. So what causes this unusual form of endocarditis? Unlike typical infective endocarditis, Libman-Sacks endocarditis isn't caused by bacteria. Instead, it's a non-infective inflammatory condition strongly associated with autoimmune diseases, primarily systemic lupus erythematosus, or SLE. While less common, it can also occur in patients with antiphospholipid syndrome or other autoimmune disorders. The underlying autoimmune disease drives the inflammatory response that leads to the heart valve abnormalities. To understand Libman-Sacks endocarditis, we need to delve into the heart's inner workings. In LSE, the autoimmune attack triggers inflammation on the heart valves, most often the mitral and aortic valves, but it can affect others. This inflammation leads to the formation of sterile vegetations, small, warty growths composed of immune complexes, fibrin, and inflammatory cells. These vegetations can damage the valve leaflets, causing them to thicken, scar, and become incompetent. This valve dysfunction can result in regurgitation, where blood leaks backward through the valve, or less commonly, stenosis, where the valve opening narrows, obstructing blood flow. Over time, this places significant strain on the heart, potentially leading to heart failure. Libman-Sacks endocarditis is not a common disease, and its exact prevalence is challenging to determine. It primarily affects individuals with systemic lupus erythematosus. Studies suggest that LSE is present in a significant portion of SLE patients, with estimates ranging from less than % to over 50% depending on the diagnostic method used, with the higher percentages seen in autopsy studies. It's crucial to remember that LSE is more common in individuals with poorly controlled lupus and those with antiphospholipid antibodies. The symptoms of Libman-Sacks endocarditis can be quite variable, ranging from mild to severe, and are often overshadowed by the symptoms of the underlying autoimmune disease. Some individuals may experience no symptoms at all, and the condition is only discovered during routine examinations. However, when symptoms do occur, they often include fatigue, shortness of breath, chest pain, and palpitations. These symptoms are largely related to the valve dysfunction and the resulting strain on the heart. In more severe cases, signs of heart failure, such as swelling in the legs and ankles, may be present. It's important to remember that because LSE often occurs in the setting of SLE, distinguishing its symptoms from those of lupus itself can be difficult. Diagnosing Libman-Sacks endocarditis can be challenging, as it mimics other heart conditions. A thorough clinical evaluation is crucial, considering the patient's medical history, especially any autoimmune disorders. The primary diagnostic tool is echocardiography, particularly transesophageal echocardiography, or TE, which provides a detailed view of the heart valves. This imaging can reveal the characteristic vegetations and valve abnormalities. Blood tests, including those for autoimmune markers like anti-nuclear antibodies, or ANA, and antiphospholipid antibodies, are also essential to confirm the diagnosis and assess the underlying autoimmune activity. It's important to rule out infective endocarditis with blood cultures, as both conditions can present with similar symptoms and valve lesions. While we don't typically classify Libman-Sacks endocarditis into distinct types, it's important to consider the severity of the valve involvement. Some individuals may have small, asymptomatic vegetations, while others may have significant valve damage leading to severe regurgitation or stenosis. The presence of complications like embolic events, where fragments of the vegetations break off and travel to other parts of the body, also influences the clinical picture. The management of Libman-Sacks endocarditis focuses on controlling the underlying autoimmune disease and managing the heart valve dysfunction. Immunosuppressive medications, such as corticosteroids and other disease-modifying antirheumatic drugs, or DMARDs, are often used to reduce inflammation and prevent further valve damage. Anticoagulation with medications like warfarin or other direct oral anticoagulants, DOAs, may be considered to prevent blood clot formation, especially in patients with antiphospholipid antibodies or a history of embolic events. In cases of severe valve regurgitation or stenosis, surgical valve repair or replacement may be necessary. Close monitoring by both a cardiologist and a rheumatologist is essential to optimize treatment and prevent complications. Currently, there's no specific method to directly prevent Libman-Sacks endocarditis. The key to prevention lies in effectively managing the underlying autoimmune disease, particularly systemic lupus erythematosus. Regular monitoring for cardiac involvement is crucial for individuals with SLE. Adherence to prescribed medications and lifestyle modifications, such as a heart-healthy diet and regular exercise, can also help to reduce the risk of developing LSE and its complications. The prognosis for individuals with Libman-Sacks endocarditis is highly variable and depends on the severity of the valve damage, the presence of complications, and the effectiveness of treatment for the underlying autoimmune disease. With prompt diagnosis and appropriate management, many individuals can live relatively normal lives. However, severe valve dysfunction can lead to significant morbidity and mortality. Recent research is focused on identifying biomarkers that can predict the development of LC in individuals with autoimmune diseases and developing more targeted therapies to reduce inflammation and prevent valve damage. Studies are also exploring the potential role of newer immunosuppressive agents in preventing the progression of LSE.